let's go ahead and get started with pregnancy this morning. Pregnancy typically takes me about 65 or 70 minutes, depending on how many stories I tell. It may look like we are running behind today. I assure you we won't run behind, all right? So let's get going. You know, I have good news for you in the realm of pregnancy. What you need to know in practice and also within the realm of what you should know for the family exam, what you have to be able to do is follow a patient who has a normal pregnancy, deliver routine prenatal care, manage those things that come up for her during her pregnancy, like a urinary tract infection, what to do about a flu shot, what if she has asthma, suppose she's on an SSRI. You need to be able to manage that. You don't need to be able to manage complications. What you need to be able to do is identify a complication and know this has got to go to whoever is going to deliver this baby. Simply because in the realm or the scope of practice of a family nurse practitioner, it's not to deliver at a planned event a baby. Your job is to be able to deliver prenatal care, all right? So that's part of your scope of practice. So this is where we're heading today, and obviously I'm going to divide this by trimesters, and we'll look at the most important things to accomplish in each of the trimesters, and I think you'll be ready and know what you need to know. You know, just of interest, I thought you might find this helpful to know who provides care to pregnant patients. And when you look at it in the United States, about 8 to 9% of people who deliver care are midwives. They're people like we are, but instead have specialty in pregnancy areas. To be honest, NPs, family NPs, probably fit in to this remainder. So we're in that group. A lot of family NPs who work in OB practices follow and actually take on a whole lot more responsibility than probably I'm going to give you today, but it's not required for your exam. So let's start, for the purposes of our discussion, with a patient who becomes pregnant, and you're going to see her in the first trimester, all right? So we'll start right at the very beginning. And the first thing that probably is going to happen, maybe you were the patient, maybe it was your spouse, your sister, your best friend, but somehow, some way, you got a clue that you were pregnant. And when that happens to one of your patients, they are probably going to do what you did, which means if they got the clue that they were late, or maybe they were like a good friend of mine who got back from a honeymoon, and I called her a few weeks later. I said, hey, how you doing? How's married life? She said, Amelie, married life is wonderful. But I had no idea it would make you so tired. I said, you better go get a pregnancy test. She said, oh, no, there's no way. Well, 9 months later, So at some point, the person who is pregnant gets a clue, and they're going to do what you did, which is go and get one of those. You get them over the counter, obviously, but you need to know about what they do. So let's take a look at the over-the-counter pregnancy tests. Obviously, those are urine-based. They're all based on the finding of HCG. That is always compared to the blood test or the serum test. A urine test becomes sensitive. What does that word mean? Sensitivity. Able to identify a condition when it really is present. So look, it becomes sensitive 9 to 12 days after conception. Do you know when that is? It's before she's late. The urine test is a darn good test. The serum test is sensitive only a little bit earlier. So I guess the point that you should take home is that the urine test is a darn good one, and that probably will be the one that you use in your office simply for convenience and because it's a good one. I think that the first question out of someone's mouth when you tell them, congratulations, you're pregnant, is usually, when am I due? Now, that's not the first words out of their mouth. It's usually the first question. And so when someone says, when am I due, I think what you're going to do is pull out either a pregnancy wheel or you'll pull out your smartphone. And most people have an app on their smartphone that allows them to figure out a due date. But listen, I use the pregnancy wheel simply because it's a whole lot faster than any app I've found. Whatever your preference is, use it. But I'll tell you that this pregnancy wheel or the app on your smartphone is based on Nagel's rule. And I put a star by Nagel's rule. Nagel's rule says that if you subtract 3 months from the last menstrual period, you add 7 days in a year, that is going to be her due date. That, of course, is based on a pregnancy that lasts about 280 days. All right, so that's about how long it lasts. I have a question for you, and it is a select all that apply. So take a look. A family nurse practitioner has just diagnosed pregnancy in a patient at 8 weeks gestation. The patient will be followed for pregnancy by another provider. What must be done today? Well, I'll tell you that if you diagnose pregnancy, and if you take care of women, you will. If you diagnose pregnancy but you don't manage pregnant patients, there are two critically important things that must be accomplished when you make that diagnosis. The first thing you must do is make sure that she is on prenatal vitamins. Circle that one. In fact, this morning I was reading that there is an additional benefit with folic acid. It isn't just to prevent neural tube effects, but it goes a long way in preventing small for gestational age births. So an additional benefit for folic acid. So you got to do number 2. And then the other one that I want you to circle is to establish a due date. You must establish a due date when you make a diagnosis of pregnancy. So of the two most critical things that you need to do when you make this diagnosis, number 2 and number 3 are certainly them. I think it's probably a good idea to make a referral, but she doesn't have to make a decision today on who she is going to see, especially if she's already got one. Is everybody with me? ACOG is an acronym for the American College of Obstetricians and Gynecologists. Their recommendation is that prenatal care be initiated certainly by what time frame? Which one is it? It's going to be 10 weeks. They would like you or whoever is pregnant to be seen prior to that time. But to be honest with you, by 10 weeks, things need to begin to get checked and screened for. And so, the pregnant patient is in your office. And you need to get some information from her, or someone does. At the very least, if someone else collects the information, you've got to review it. These are some of the most important things to pick up, or clues to collect in patient history. Certainly the first question I ask when I meet or diagnose pregnancy is, have you ever been pregnant before? I want to know that because my next question is going to be, how'd they go? If she tells me, I get pregnant very easily, this is the 6th time I've been pregnant, I just can't get past the first trimester. If they tell you that, then I know right away she's not my patient. She's going to see somebody PDQ. If she tells me, oh, I have 4 at home, then she probably knows more about it than I do. So my first question is always, have you been pregnant before? Tell me about them. Obviously, you need to know what medication she's on. Very, very critical. So you'll collect all of this information. But to be honest with you, with regard to your exam and with trending in the country, the last bullet is something you need to know about. Look, it says psychosocial information. This is what ACOG and AMA want you to do with every single pregnant patient. Every single one of them needs to be screened for domestic violence. They want routine screening no matter who your patient is, no matter what socioeconomic level she is in. The reason for that is because domestic violence is incredibly common during pregnancy. Look at the numbers in the United States, and these are reported numbers. So like this is reported. Can you imagine how much is not? Look at the numbers. 7 to 20% of pregnant women are physically abused. If you take care of an at-risk population, you know what I know? You're in the 1 in 5. You're in the 20% of people. So what I would tell you is you need to make sure that these people are screened because they do have more problems during the course of pregnancy than people who are not abused. So what clues will you look for? Who is at increased risk? I would tell you that if she is single and young, she's at increased risk, especially if she was abused as a child. Now, what clues to domestic violence will you look for? These are big clues, and they ought to be very obvious to you. We look for people with improbable injury, people who have a story that doesn't match the injury that we see in them. But a big one is people who miss their prenatal visits, and especially people who cancel at the last minute, and it becomes a habit. Those are people who you ought to have red flags on when you finally get to see them. So these represent very important clues for your picking up a patient who's being abused. Everybody with me? Let's look at your physical exam, because after you collect your important historical information, a good head-to-toe physical exam is always in order in a patient who's pregnant. With regard to a pap smear, the cervical screening schedule that she was on prior to pregnancy is still good through pregnancy. The screening schedule doesn't change because she has become pregnant. Someone in your office, maybe you, is going to weigh her and find out how tall she is. Now, we don't think she's going to grow in vertical height during the pregnancy, but the reason we want to find out how tall she is and how much she weighs in the first trimester is to make sure that we can establish a BMI. You got it? ACOG is all about BMIs right now because it lets us know how much weight the patient can safely gain. So we'll talk some more about that a little bit later, but to be honest with you, establishing a BMI right now is going to be very important. If your office routinely takes care of pregnant patients, I would tell you that you're going to have a standard set of labs that you get with every patient on a first prenatal visit. Let's look at what is commonly used across the country. I always think about doing first things first. No one in this country will pay you to deliver prenatal care unless you have established that she's pregnant. So it doesn't matter if she walks in and tells you, Amelie, the last 12 mornings in a row, I've checked and I've got blue lines the last 12 mornings in a row. I am pregnant. You got to do it. You got to find out. You have to do one in your office. You got to get an ultrasound if that's called. You got to establish that she's pregnant. That is the very first thing you must do. Look at this question. A pregnant patient has an MCV of less than 80. What are you thinking? What's the word we use? Microcytic, right? So she's got an MCV less than 80. There is no iron deficiency anemia. Okay, wait. Iron deficiency anemia is microcytic anemia, right? It's not iron deficiency. She's got a microcytic anemia. What's the likely cause? Thalassemia. Very good. So I want you to circle number 3. And one of the reasons that we check an MCV in pregnancy is to find a patient who may have thalassemia. We need to know that as providers. So look at what else we do. After you get a positive pregnancy test in some way, shape, or form, we always screen for anemia. And here's why. Pregnancy produces a state of, dilutional anemia, which means that she's going to have the same number of red blood cells on board, but there may be more fluid. If there's more fluid, we call that a dilutional anemia. If pregnant mom comes into the pregnancy with anemia, and we know the dilutional anemia will go on as well, you got your work cut out for you. So one of the most important things as part of this initial screen is to find out whether or not she's anemic and whether or not she's got thalassemia or some other anemia. Look at my next question for you. A pregnant patient has been found to have asymptomatic bacteriuria. I'd like to know how you think it ought to be handled and how ACOG would handle it, which ought to be congruent, right? Ought to be the same. Listen, they typically consider monthly urine screening until delivery if you have asymptomatic bacteriuria. That tells you how important it is to identify it and get it treated, which is what number 2 is. When you identify asymptomatic bacteriuria in a pregnant patient, we always treat it. For those of us in this room who are not pregnant, if you had asymptomatic bacteriuria, we would watch you. We don't necessarily give an antibiotic. So a big difference in the way we manage a pregnant patient and a non-pregnant patient with asymptomatic bacteriuria. And so I think your best answers for this question are number 1 and number 2. All right, so increased surveillance and aggressive management. And that leads us to why we got the urine. We get a urine, obviously, to see if she's got asymptomatic bacteriuria, but we're going to get urines and collect them frequently throughout her pregnancy. What are we looking for? Well, we're always looking for bacteria for obvious reasons. We're looking for glucose, protein, ketones, but it depends on what trimester she is in as to which one we're most likely to find. Let me give you a clue. When are we most likely to find glucose or ketones? Second trimester, when we're more likely to identify what? Gestational diabetes. When are we more likely to identify protein in her urine? In the third trimester, when she's more likely to exhibit preeclampsia. So while we look for all of these things every time we do a urine dip, certain times during her pregnancy, we will be more likely to find one thing or another. So again, urinalysis, very, very important. As is her blood type. Remember that about 15% of people in the United States are Rh negative. If your pregnant patient happens to be one of those Rh negative patients, then you just got an extra job on your list of things that you need to get accomplished. What's that extra job? She needs RhoGAM, exactly. So we got to know what her blood type and Rh is. I'll tell you what the standard of care used to be. I have friends who used to deliver babies, still deliver babies, and this is what the standard of care used to be for Rh negative women. They would say, oh, Miss Boudreaux, Miss Boudreaux's too old. Let's get Miss Smith. Miss Smith, Wendy, you're Rh negative, and that could produce some problems in your pregnancy. Next time you come in, we want you to bring your husband because we're going to check his blood type. Problem? Big problem. What was the big problem? The husband was not always the father of the baby. Now we don't even care, right? So we say, oh, Wendy, you're Rh negative? We got interventions for you. We don't even ask any questions. We don't need to know. So anyway, obviously, it is very, very important. What problem can be produced? Hemolytic disease of the newborn, obviously. So RhoGAM we'll talk a little bit more about later. There is something else as part of that initial screening, and we need to know whether mom is immune to rubella. And we hope she sure is, because if she gets exposed to that during her pregnancy, miscarriage and other things result. We don't want that to happen. So we're going to find out whether or not she is immune. Sometimes there's a question on the exam that gives you a patient who is pregnant who is not immune. And they'll ask you how you handle that. They say, we immunize her now, immunize her after birth, don't worry about it, what you going to do? And typically you say, what is it? We immunize after birth, never ever during pregnancy, right? And what other instructions do you need to tell her if she's not immune? She needs to avoid contact with anybody who may have been infected or who might be infected. Unfortunately, you don't always know that, right? What else do you have to do on your initial set of labs? Well, you know what? Both ACOG and CDC want you to screen every single pregnant woman for sexually transmitted infections. And obviously it's important. So again, we'll be doing screening for STIs, and I would encourage you to do that. When you identify one, you got to treat it. But let me tell you something else about identifying an STD early in pregnancy. You better screen her again later on, because people who come into your practice infected and pregnant tend to become reinfected as the pregnancy progresses. So I would encourage you to rescreen and retreat if you need to. Sometimes your exam, and many times in practice, you get a patient who is pregnant who has hypothyroidism. Big deal? A very big deal. Here is why. If mom has hypothyroidism with a normal TSH, as she becomes pregnant and her pregnancy progresses, her needs for levothyroxine will increase. If that's who your patient is, you have got to make sure that you stay ahead of her needs, because you need to make sure that her TSH remains in normal range, because if it doesn't, it can result in delayed neurologic development in the fetus. So while the recommendation may be to get pregnant patients into endo if they have hypothyroidism, good luck getting them in, right? They'll deliver often before we can get them in. Your job is to make sure that your TSH stays within normal range. How much is normal range? To be honest with you, most of the learned endo authorities want a TSH less than 2.5 if she's contemplating pregnancy, and while she's pregnant, to make certain that we stay ahead of her needs in our supplementation. So again, following those TSHs are critical in our patients with hypothyroidism. Well, ACOG has some other things that they would encourage you to get, but not routinely in a pregnant woman. If your pregnant woman is considered at risk for any of these, ACOG says you ought to screen her. So we don't routinely screen for these, but I want you to be alert that sometimes we do. And we always do if the patient is at risk. All right, I got a question for you. I want you to be very honest when you answer this. How many people in this room want to have a sign made for the front door of their clinic that says this: no pregnant women allowed in this clinic? Please raise your hand. All right, we have several people. Thank you for your honesty. Of all the people in this room who ought to know the answer to this question, it is you. Look at my question. When is a patient with an ectopic pregnancy most likely to present? Like, when are they coming in? When do you need to have a heads up? When do you have symptoms when you have an ectopic? I want you to look at number 3. 6 to 8 weeks after the last menstrual period, that is the most likely time for them to come in with symptoms. Amelie, what symptoms? The classic symptoms are these. They come in with abdominal pain. Often there's vaginal bleeding. Is their pregnancy test positive or not? Oh, it's positive, right? Because they're definitely pregnant. What's the problem? The pregnancy is not where it's supposed to be, which is what the word ectopic means. Very often, that egg is in the fallopian tube, and you know as well as I do, a fallopian tube doesn't have enough stretch and tissue to accommodate a growing fetus, so that's going to be a problem. Who's at increased risk? I'll tell you, anybody with sticky, not stinky, but sticky tubes is going to be at increased risk for an ectopic. And if you've ever had one, your risk is going to be increased as well. So anyway, take a look at those risk factors and have a heads up if your patient's got one of them. You remember I told you that we wanted to measure how tall mom's vertical height and her weight? It was always to establish a BMI if we got her in the first trimester. ACOG right now is all about BMIs, and here's why. They want to make sure that pregnant mom gains an appropriate amount of weight. If she gains more weight than is considered appropriate, then risks begin to go up for her and the fetus. Consequently, I would never put these numbers in my brain. The space in your brain needs to hold way more important information. What I would put in my brain is the BMI of a normal patient, or a normal BMI in a patient, 19 to less than 25, and how much weight that patient should gain. So an average weight or BMI patient ought to gain about 25 to 35 pounds during pregnancy. If her BMI is less than that, she probably ought to gain more. If her BMI is more than that, she probably ought to gain less. And that's how I would handle that issue. All right? So remember normal and then go up or down from there. Everybody good? Well, the next topic is exercise in pregnancy, and I know you know how I feel about it. Exercise is the fountain of youth. Exercise is good for everybody except a patient with unstable angina, right? Everybody else profits from exercise, and so do pregnant women. There are about 3 exercises that I can think of that should be off limits for a pregnant woman. And here are the 3 I think of. 1, bungee jumping. Like, please don't let them do that. Number 2, deep sea diving. They don't need to do that either. And what about skydiving? Like, don't let them do that one. So almost any activity that pregnant mom engaged in prior to becoming pregnant, she can engage in as a pregnant woman, especially as long as she feels comfortable. But have the conversation with her because it's important. Well, look at this slide. And I guess I'm going to stop and tell you a quick story. Listen. You probably need to begin to change the way you think about yourself right now. Because right now you might think about yourself as a brand new NP or a new NP who has loads to learn. That is not the way the general public views you. The general public views you as a very learned healthcare provider, and they're willing to give you their hard-earned money to get a small piece of your time. They want to know what you have to tell them, and they're willing to pay for that. When you begin to think about things in that regard, you will quickly realize that the words that come out of your mouth have way more gravity than you might have thought. So it means a whole lot more when you look at a patient and you tell her you're pregnant and alcohol or cigarettes or illicit drugs don't belong in you right now. It means way more coming from you than their neighbor, their coworker, their sister, or their mama. You got it? So you need to begin to think like that. But as you do that, I want you to begin to change the way that you look at yourself. All right? So starting today, think of yourself differently, because the way you think of yourself, even if you have 30 years of experience under your belt, you don't think of yourself the way the general population does. All right? I'm off my soapbox. Have the conversation with your patient. What about cramping during pregnancy? Well, it may be completely benign because it may be due to growing, stretching of the uterus, or it may be an ominous finding, meaning she needs to come in and get checked. These usually come in order of a call to your office. How are you going to handle that call? A good question to always ask is this question. You always ask them, is the cramping that you're having right now worse than it was 2 hours ago? Is it worse than it was 4 hours ago? And the reason you ask that question is because cramping that worsens over time is an ominous finding. That patient needs to come in and get checked. You got it? So that will help you discern, is this one I need to be worried about, or is this one that probably I can follow up with just a phone call? Everybody with me? You good? All right, let's keep going. What about exposure of pregnant mom to infectious things? We always worry about that. Your patients will as well. There are a lot of febrile illnesses that we want to make sure she avoids if she possibly can. The most common one, I guess I'm thinking of this right now because of flu, and we are beginning to see multiple cases of flu right now down in South Louisiana. That certainly is one of them. But all of these are examples of things that you need to have a conversation with mom about. She needs to eat food that's properly cooked. She needs to avoid people with febrile illnesses. So please have that conversation with her. What about immunizations during pregnancy? Maybe I'm telling you how old I am, but to be honest with you, there was a time when we didn't want to give a pregnant woman any immunization. And now we realize that we were wrong. We realize that it is important to keep pregnant mom very healthy. And a safe way to do that is with immunizations. Flu. There was a time when we would never give a pregnant woman a flu shot. Now we want to make sure she gets it. We don't want her to get influenza. What about Tdap? I think you'll see a question on the exam about Tdap, because it's a hot issue and it's been hot for at least 2 or 3 years. You know, CDC and ACOG combined on a new recommendation for pregnant women. They want to make sure that every pregnant woman gets a Tdap immunization, you ready, with every pregnancy. It doesn't matter if she gets pregnant 7 years in a row, she used to get 7 Tdaps in a row. Like 7 years of bad luck? I don't know. But anyway, you got my point. So Tdap, but when does she get it? 3rd trimester, right? All right. And so we need to make sure she's up to date on immunizations depending on what's available and what time of year it is. You have a lot of information to give this pregnant woman, especially if she is pregnant for the first time. As part of your teaching plan for her, there are some things that you need to tell her no matter how many times she has been pregnant, because these things are so critically important. And here are 3 or 4 of them. You need to make sure that you tell her that anytime there's an escape of fluid from the vagina, whether it's clear, it's bloody, it's odorless, it has an odor, she needs to let you know right away. That's got to be part of your teaching plan. If she doesn't perceive fetal movement, she's got to let somebody know, PDQ. And then finally, as part of your teaching plan, regardless of how many times she's been pregnant, you need to talk to her about the signs of preterm labor so she knows what to expect and what to do. Whew. That was like the first visit. Let me ask you something. Do you think you should be paid at least double to take care of a pregnant woman? I think you should. Yesterday I told you triple for a diabetic. I think double for a pregnant patient. I'm serious. Especially if it's the first time she's been pregnant. So listen, we finished with that visit. When is she coming back? The routine schedule in the United States goes like this. We see her every 4 weeks until the end of the 2nd trimester, which is 28 weeks. Then we see her every couple of weeks until about 36 weeks. And if you haven't made some arrangements with somebody or sent them over yet to the person who is going to deliver this baby is probably a very good time at about 36 weeks. So anyway, that's what we typically do, and this is routine in the United States. And so let's talk about the most important things in the second trimester. Generally, when she comes in, you and someone else is going to collect the same information that you've been collecting. You want to know her blood pressure. You want to know what her weight is doing. Well, typically, what does blood pressure do in the second trimester? Up, down, or stay the same? It drops a little bit, right? It drops a little bit. A clue to you is that if pregnant mom comes into the pregnancy and she's 80/60 normal, she may have some episodes in the second trimester with some lightheadedness secondary to orthostatic hypotension. Just have a heads up about it. I am pretty sure that if she came into the pregnancy anemic, you'll be checking where she is again. You'll check a CBC or however you evaluate anemia in her. You're going to ask her to urinate in a cup. We're always looking for the things we talked about, but what are you most likely to find in the second trimester? Glucose and ketones, because this is when, if she's going to exhibit it, gestational diabetes is most likely. And so that brings up screening for gestational diabetes. It is critically important, and every learned provider in the United States, or learned authority, agrees that 100% of pregnant women ought to be screened for gestational diabetes. You know why? Because it's so darn common. Up to 18%, that's like 1 in 5 pregnant women, has gestational diabetes, so we got to screen them. Every learned authority in the United States agrees that the best time to do it is at 24 to 28 weeks. But we don't have consensus about the best way to do it. I want to introduce you to both ways, and I'll show you what you typically see on the exam. And so, here's the deal with gestational diabetes. We want to screen everybody. It's darn common, and the reason we want to screen everyone is because if mom has gestational diabetes and it's not aggressively managed, these are the complications that can ensue. Loads of them with the fetus and problems with mom as well. So we screen everybody. There are 2 terms with regard to diabetes during pregnancy that you need to differentiate. One term is called overt diabetes. That term means mom had diabetes and then she became pregnant. Gestational diabetes means she got pregnant and then she developed diabetes, all right? So I would make sure that I could differentiate those 2 terms. If mom has overt diabetes, we want to know how good a control she is in. Or maybe we suspect that she may be diabetic and we'll screen. Typically, we do this at the first prenatal visit. If there's a question about it, look at how we screen her. Do you recognize these? Same way we made our diagnosis of type 2 diabetes in our adults, remember? We used a fasting glucose, we used an A1C, and we used a random. So I would tell you, we want to pick these patients up and get them treated. So listen, how will we screen them if it's not overt diabetes? For gestational diabetes, there are 2 options in the United States for screening. There is something called the 2-step, which means we're going to use 2 different steps if the screen is positive. That's recommended by ACOG because it is least expensive, but it's not so convenient if it's positive. The most convenient and most expensive is the 1-step. So let me show you what the difference is. The 1-step uses a screen and a diagnostic tool in the same step. Very convenient. Mom comes in fasting, boom, she gets a test, and we know right then. The 2-step is this. Mom comes in, whether she's eaten or not, we really would like her to eat. She is going to consume 50 grams of glucose. How many people have tasted that stuff? Raise your hand. Every hand in this room ought to go up. Gentlemen, you ought to do it too. Anything you ask your patient to do, taste, drink, put on them, you need to have done it, unless you got a good reason not to. When you land wherever you're going to land, I want you to go to the lab that's going to do a lot of your testing. I want you to walk in and introduce yourself, and I want you to ask them, listen, I'm curious about the taste of y'all's glucola or whatever substance they use. Can you let me taste it? They will be happy to give you a taste. And when you taste it, you'll know why pregnant women often do what after they consume 50-gram glucose load. What is it? They vomit. It's very, very sweet. So what you will do with this pregnant woman is have her come in preferably after she's eaten, she's going to consume her 50-gram glucose load, and in an hour, the lab is going to check her blood sugar. If her blood sugar is 130 or greater, then she has a positive screen. She needs to come back on a different day for the second step. On a different day, preferably this week, can you come tomorrow? Oh, you're busy tomorrow, can you come Friday? When she comes back this second time, now she has to be fasting. And what we'll ask her to do now is consume 100 grams of glucose. So she had trouble with 50. You can predict what might happen with 100. We're going to check blood sugar, the lab will, 4 times. They check it before she consumed glucose load, so she'll get checked fasting. She'll get checked an hour after she consumes her glucose, at 2 hours and 3 hours. You will end up with 4 glucose values. You might get a question on your exam. Certainly you see it in practice all the time. How do you interpret these results? This is how you interpret them. If 2 of your 4 glucose values is abnormal, then she's got the diagnosis. So if 2 of the 4 values is abnormal, she gets a diagnosis. And do you think you have to memorize those lab values? Absolutely not. They will give you mom's values and they'll give you the expected values. What you look for is 2 of the 4 being abnormal, and boom, she gets a diagnosis of gestational diabetes. Now that you just diagnosed her, what are you going to do? You're going to say, Mom, we need to make sure that your glucose gets back to an appropriate level. I want you to see a registered dietitian. The registered dietitian is going to be able to help her with small, frequent feedings or meals and help her figure out what to eat so that her blood sugar can get to a normal range. Then, if you manage this, or maybe you send them over to someone else, depends on the resources in your community, you have 2 ways to consider managing her glucose. Some places will go straight to insulin, and that's been the standard of care for a very long time. But ACOG now allows oral agents like glyburide and metformin, provided it is outside the first trimester. ADA doesn't like that idea. ACOG thinks it's a good idea. So I would tell you that unless you're savvy in this aspect of care for a pregnant woman, you probably need to get some help, especially because this woman is going to be a patient who's going to be at increased risk. And so will the fetus be as well. So anyway, this is typically how it's handled, but you need to get some help right after you make that diagnosis. Everybody good? Second trimester, another big deal is assessing fundal height. I want you to put a star by McDonald's rule. McDonald's rule says that between 18 and 34 weeks, there is very good correlation between gestational age and fundal height. That's what it says. I remember when I took my RN exam, I had a question just like this one. I remember that when I took my NP exam, I had a question just like this one. And I continue to hear year after year that there's a question just like this one on the exam. So I would have a heads up if you're going to be an exam taker. So anyway, McDonald's rule. Something else that happens in the second trimester is to do either a triple or a quad screen. And the best time to do it, honestly, is between 15 and 22 weeks. That's what the learned authorities tell us. And I got to do a wind back to sophomore biology. You remember with sophomore biology, you learned about chromosomes and pairs of chromosomes. And everybody in this room has 23 sets of chromosomes. One of those sets has determined your gender. The rest of the sets, the other 22, have determined every single characteristic about you. How tall you are, the color of your hair, your eyes, probably what disease you're going to die of. On your exam, there are 2 common chromosomal abnormality questions. One of them you'll certainly nail. The other one I want to make sure you nail. The most common chromosomal abnormality that we see in live births is Down syndrome, and you know that. Instead of having a pair of number 21s, you have 3 number 21s. And if you are an individual who is born with 3 number 21s, then you will be an individual who is born with a particular set of physical characteristics. You know that one. The other chromosomal abnormality that maybe you don't know, and I need to make sure you do, is Turner syndrome. Turner syndrome is the most common sex chromosome abnormality, and I think that's why they ask questions about it. Here's what happens in Turner syndrome. It always happens in females, XX, right? So this is what happens. Look, pretend this is an X chromosome. In Turner syndrome, either all or part of one of those X chromosomes is lost. You got it? The lost piece of information can't contribute to the live individual. Consequently, that individual is going to be a human being who is born with a particular set of physical characteristics. Like what? She tends to be short in stature. She tends to have a square chest. She typically has no female reproductive organs that will allow her to reproduce. And if you didn't know that and you examined her, it would be obvious when you examined her, right? It should be. So that's Turner syndrome. I think you may see a question about it because it is so darn common. Everybody with me? Second trimester, what's a big deal for mom? The perception of fetal movement. What do we call that? Quickening, exactly. Most common time in a prime-ip is about 17 to 20 weeks. After mom has had pregnancies, she gets it a little bit earlier, all right? So quickening is a big deal for mom. All right. There are some things in this world that we just know by their brand name. For example, if I sneezed and I said, "Do you have a Kleenex?" But you gave me a Puffs, I would take it. Well, my whole life, I've only ever known Rogam by Rogam. That's a brand name. Rogam is anti-D immune globulin, and that might be the term you see on your exam. If that's what you see, I want you to realize it is Rogam. So with that, let me show you this question. A pregnant mother is Rh negative. When should she receive Rogam? When does she get it? She gets it in the second trimester, right? When? About the 28th week. So circle number 3, during the second trimester, but she might need it again. Let me make sure you know when. Suppose a baby that is born is Rh negative. Does she need another shot of Rogam? No. Suppose a baby that is born is Rh positive. Does she need another shot of Rogam? Yes, right? So we determine the need for that second Rogam injection after the baby has been born, and we have determined the Rh status of the baby. You got it? So if she's Rh positive, the baby's Rh positive, she needs another one. If the baby's Rh negative, she got that one at 28 weeks and we're good. Everybody with me? All right, let's keep going. I wish that you could get paid for the amount of education that you need to do with a pregnant patient, especially if it's the first time she's ever been pregnant. As part of your plan for her and the education that she needs, you have to address every single one of these, and I gave you a clue about it a little bit earlier. We want that addressed in the first trimester, but it's time to begin to make sure she gets that again in the second trimester. So talk to her about the signs of preterm labor. Tell her that she should perceive fetal movement every single day. Ask how she intends to feed her baby. Sometimes you'll see the most surprised look on her face you ever saw in your life. You know, I got daycare arranged. I never thought about how to feed her. Well, let's talk about it, because breastfeeding is a great idea. So have that conversation, and then let me tell you a joke on me. You see this last bullet, car seat? This is what happened to me. I was sitting at home one night, and one of my brothers called me, and he asked me if I would be able to take care of pick up his son, 2 years old at the time, who was going to be in daycare after I got off of work the very next day. I said, "Oh, I'd love to." He said, "Well, listen, I'm going to come by your house tonight, and I'm going to put his car seat in your car so you don't have to come and get it from me tomorrow." Great. The next day after work, I drive over to the daycare. I sign him out, and we're walking back to my car. I open a back door. I pick him up. He's 2 years old. I put him in his little car seat. I take the 2 straps, and I pull them over his shoulders. I take the one between his legs, and I pull it between his legs. And now I have these 2 things I have to figure out how to connect. And so I'm like working and I'm pulling him back and digging behind him for another strap. I mean, something is wrong. I can't get this thing. I must have worked for 8 or 10 minutes and I couldn't connect it. So I stick my head out of the car and I'm looking for somebody, like a parent or somebody who can help me with this seat. There's nobody around. I stick my head back in the car and I look at him and I said, "Do you know how to do this?" He takes the 2 ends and goes, I was so embarrassed. I kept thinking, thank God he's only 2 and he doesn't talk a lot, because if he told somebody this, I'd be so embarrassed. So I close the door. I walk back around and get in the driver's seat and I'm driving home. And I continued to have the same thought on my way back to my house. All I could think of was, he probably thinks his father has left him with an idiot. I've never heard the story, so I suppose he really was not able to tell anybody the story, which I'm grateful for. So do not tell that to anybody in my family if you meet them, all right? All right, so second trimester, if you got those things we talked about covered, you got it. Third trimester, what do you need to accomplish in the third trimester? Well, when she comes in, somebody, probably you, is going to ask about all the things we've been asking. How you feeling? Escape of fluid from the vagina. How you doing? You have a problem you had in the second trimester. How is it? You're going to ask all of these things, and you're going to get another urine specimen. What might you expect to find in the third trimester? Proteins. Most likely time to find it. Obviously, we could find any of these, which brings up this important point. When you do your screen for gestational diabetes, it doesn't pick up everybody with gestational diabetes. It misses some people. So listen, if your patient who had a negative screen for gestational diabetes is now exhibiting symptoms of elevated glucose, you need to screen her again. You can do that gestational diabetes screen as many times as you need. If she's got symptoms, check it. And it may be that you need to do it again in the third trimester, depending on what she tells you. And so, remember I said that if you identified an STI in the first trimester or the second one, you need to screen her again and treat. A very good time to do that is right now when she comes in the third trimester. She's going to get undressed and somebody is going to check her, do an ultrasound. You may do a vag exam. You'll check her. And then you're going to look at her and say, "Mom, I have something really important I need you to do. I want to make sure that you pause every day and feel movement. If you don't feel movement, you need to call me right away." In the United States, in most locales, we call that kick counts. It's a very important thing to get mom to begin to do in that third trimester. So get her to do it and give the appropriate instructions. What else is critical in the third trimester? You remember on, 2 days ago, it feels like longer than 2 days ago when we talked about Group B strep. You know, we talked about strep with antibiotics. Does it seem like longer ago than 2 days? To me too. All right. We talked about Group B strep in pregnant women. You must screen now. A critical event in the third trimester is to make sure that mom gets screened for Group B strep at 35 to 37 weeks. And the reason we do that is because if mom's infected and that baby gets infected, tell me about it. Sepsis. Very, very high morbidity and mortality associated with Group B strep infection. Somebody did this analysis one time. They said, it costs $30 to hang a bag of ampicillin to prevent Group B strep infection in a mama and a baby. The average cost to treat a Group B infected baby is $300,000. It is so cheap to prevent and so expensive to treat. So of the things that you think about in the third trimester, this is like a major big deal, all right? Is everybody good? Let's talk about some common discomforts that you'll see in pregnancy, and you should feel very comfortable in being able to manage them. A lot of times management of these things involves your prescribing a medication, which is why it's so important for you to know about the pregnancy categories. I read one time that the average primary care provider prescribes about 50 medications. 50 medications is what you prescribe all the time. Of the medications that you prescribe all the time because you're comfortable with them and because you know them very well, One of the things that you must know about each one of those meds is its pregnancy category. Can you give this to a woman who says, I don't know, I might be, I'm thinking about it, or I am? What are those pregnancy categories? So here they are. The FDA ranks every medication as far as pregnancy category, and it goes like this. It's A, B, C, D, and X. It's kind of like grades in school, I guess. A's and B's are what you always want. You would like to expose a pregnant woman to an A or B. You would never want to expose a pregnant woman to a C. A C means if you decide to give that drug that's a C to a pregnant woman, the benefits better outweigh the risks. And a D and an X are classes of medications or categories of meds you never want to put in a pregnant woman. So let me tell you what my idea is. I want to petition the FDA. I want to know who's going to come petition with me. I want to change the pregnancy categories. I don't want to have this ABCDX business. I want to have green, orange, and red. The green drugs are going to be the A's and B's. The orange is going to be a category C. And the reds are going to be D's and X's. Does that sound simple to you? It's so simple to me. Everybody would know. If you drive a car and you know stoplights, you know about it. So I'm ready to petition the FDA. What do y'all think? You can come petition with me? All right, good. All right. I'm going to send you an email. I'll tell you when and where. You know I'm kidding, right? I'm not kidding about green, orange, and red. I'm just kidding about coming to petition with me. But I don't know. I'll entertain any ideas that you have. Look at this question and help me with it. A pregnant patient in her first trimester has mild persistent asthma and has used inhaled budesonide, which is Pulmicort, twice daily prior to pregnancy with good results. So she's got asthma well controlled as long as she takes this med. The question is, what should be done with this medication during pregnancy? Well, if you get the bulletins that ACOG sends out because you take care of pregnant women and you need to make sure you're on top of it, one of the bulletins you would have gotten was something that said that pregnant women need to be able to breathe. Meaning, if your pregnant patient has asthma, you need to make sure that her asthma is well controlled. If this woman's asthma is well controlled on this medication, then you need to leave her on it during pregnancy. You got it? So don't try to pull her off. Your best answer is going to be continue at the same dose. All right? So anyway, number 3 is your best answer. What about this one? Which antibiotic is considered a category B, Amelie's green, for a patient in her 3rd trimester of pregnancy? Well, we need to talk about antibiotics right now. Letter A is a category B. That's going to be your best answer. It's something that you should feel comfortable and confident in using in a pregnant patient. Number 2 is levofloxacin. Levofloxacin is a quinolone. It's a category C medication, which means if mom's about to die because she's got pneumonia, I think we're going to give her levofloxacin. Otherwise, we're not going to expose her to a quinolone, and the reason we won't is because quinolones have the potential to impair bone and cartilage formation, which means we don't want that going on in a fetus. So, number 2, not on my list of choices for this answer. Look at number 3, trimethoprim sulfamethoxazole. What antibiotic is that? Bactrim. You learned a rule that was a very good rule to learn. The rule you learned was don't give a sulfa drug to a pregnant patient. Good rule. The reason we don't use sulfa drugs in pregnant patients is because of this. We never use it in the first trimester. Do you know how Bactrim kills MRSA? It doesn't let MRSA make folic acid. And MRSA needs folic acid to survive. So, you get it? We never want an absence of folic acid in a pregnant woman, so we do not want Bactrim on board in the first trimester. Excuse me. We don't want Bactrim on board in the 3rd trimester because we know that sulfa drugs decrease amniotic fluid volume, which means we don't want that going on either. If you had to sneak in A sulfa drug, you could sneak it in the second trimester, but don't do that. The rule you learned is a good one. Avoid sulfa drugs in pregnant patients. What's number 4? Number 4 is doxycycline. It's a tetracycline. That's considered a category D. Why? What's the deal with that one? Why don't you want that in a pregnant woman? Especially first trimester. Why? It discolors fetal tooth enamel. Exactly. So of these meds, I think you should have a good feel for them. This is just part of your walking around knowledge. Which one's a category B? Number 1, amoxicillin with clavulanic acid. Everybody with me? Let's keep going. Look at this one. A pregnant patient is taking sertraline. What drug is that? Zoloft. What category? What class? SSRI. She's taken it for the past 10 years with excellent results. She asks if this is safe to take when she's pregnant. How will you respond? What are you going to say? Let me check my Hippocrates. Hold on. Okay, so you pull out your smartphone and maybe you just walk around with this and you know it's a category C. And so what you have to tell her is it might be safe. You know the question I'm going to ask her? Why were you put on this medication? If she looks at me and says, Amelie, this drug saved my life. If I'm not on this drug, I'm suicidal and homicidal. Refill, right? That's what I'm going to do. I mean, so you got to have a conversation. Document the conversation that you have with this patient. All right? So I would circle number 3. All right, you ready? You do not need to be able to manage these 3 complications. What you need to be able to do is identify them and realize, I got to get this patient out to another provider. One of the pieces of instruction that was part of your teaching plan with this patient was to let you know if there was any escape of fluid from the vagina. Bloody, clear, odor, no odor, let me know. Suppose she calls you and says, Amelie, there's a fluid escaping from my vagina today. Come on in, right? What are you worried about? We're worried about it being what? Amniotic fluid. One way that we have to assess what's coming out of the vagina is to check the pH. Nitrazine paper can come either on, like, it comes in strips. Sometimes it comes like on a little Scotch tape roll, kind of. Did you hear me? Scotch tape. It's supposed to say clear adhesive tape. All right, so brand names, there we go again. So this nitrazine paper, doesn't matter what you dip it in, it'll change colors depending on the pH. The first use of nitrazine paper was not in the medical field. The first use of nitrazine paper was in geology. They used it to determine the pH of soils, and that's how they knew whether this could grow in there or that could grow or wouldn't grow, or what had been in there 200 years ago. So pH paper is very valuable, and we use it in taking care of pregnant patients. Here's what we do. If the fluid that is escaping from the vagina turns that pH paper orange, then typically we think it's acidic, it must be vaginal secretions, or it might be vaginal secretions. If what that pH paper touches turns it blue, then we say, oh, this could be amniotic fluid. I need to send you to whoever's going to deliver this baby, all right? So here's how I remember the difference. I remember that vaginal secretions must be acidic because the acidity is protective. It keeps things from growing in the vagina that shouldn't be in there. I remember that amniotic fluid must be pH neutral because I would never want a baby floating around in acid. It's got to be pH neutral. So amniotic fluid turns that pH paper blue, be on high alert. If that's what happens, you need to find out if that's what it is. Another way that we have to assess this escape fluid from the vagina is to look for something called ferning. Ferning is this. Woman says, I have this escape of fluid from the vagina. You're worried about it being amniotic fluid. What you will do is take a swab from the posterior vaginal fornix. You put it on a slide, let it slide dry for about 10 minutes. You put it under the microscope and you look. If that's amniotic fluid, it's going to have a load of estrogen in it, and it will likely dry in something called a ferning pattern, because that's what happens when amniotic fluid dries. So it's called ferning, and if you identify ferning, there is only one thing you should think of. That is amniotic fluid, and this patient needs to go see whoever is going to deliver her. So we look for ferning, which is pathognomonic for amniotic fluid leak, all right? Everybody with me? Let's talk about placenta previa. And you know what this is. This is where the placenta implants too low in the uterine segment. And what is our famous finding? Painless vaginal bleeding. Please put a star by it. When are we most likely to identify this? End of the second or beginning of the third trimester is when placenta previa is most likely to be identified. What's your intervention? Whatever you do, don't do a gloved vag exam. Refer is exactly right. You know what will be done with her is an ultrasound, because we want to find out what is where. And an ultrasound is a safe way to figure that out. So again, yes, you're going to punt. Look at this next question. What's the characteristic of abruptio placenta? Well, I'll tell you, number one is a characteristic. It's abrupt onset of vaginal bleeding. Typically, these patients have either abdominal and or back pain, so number two is appropriate as well. Number three says they have some bloody vaginal discharge. We often see that one, or we always do. And when is it most likely to occur? End of the second, beginning of the third trimester. All four of these are characteristic of abruptio. What are you going to do for that one? Get them out of your clinic, PDQ, right? Because I don't like catching babies in my clinic. I get them out of there. Last thing you need to be prepared to talk about is preeclampsia. And unfortunately, we see a load of this in the United States. We've had a number of different organizations who deliver guidelines and information about taking care of pregnant patients, and we really have not had good consensus on a definition for preeclampsia. I'm going to give you the one that ACOG uses. It was updated in 2013, and here's ACOG's definition of preeclampsia. It's the new development of hypertension and either proteinuria or end organ dysfunction after 20 weeks of gestation, and that's usually preeclampsia. So I feel like they're trying to tell you what it is, but they just kind of tiptoeing around so they want you on high alert for, look, elevation in blood pressure and either proteinuria or end organ dysfunction. What is end organ dysfunction? Man, you don't want to see this. Heart failure, pulmonary edema. She comes in short of breath. She's got thrombocytopenia. You need to get that patient out of your office as quickly as you possibly can. As far as the diagnostic criterion for preeclampsia, if you don't know, you need to know that proteinuria was removed as an essential criterion. You could have end organ dysfunction and you would still have this diagnosis. Edema. Has it been a criterion for years now? We still look for it because it's a flag for us that something may be going on with this patient. But one more time, end organ damage is a big deal, right? So what are you going to do with this patient? Oh, I'm getting her out. I got whoever provider she's taking care of her on speed dial, and I want to talk to him right now. No, go get him out of her room. I need to talk to him right now. This patient needs to be seen very urgently. So take a look at the last set of facts I think you need to know. Sometimes on the exam and always in practice, you'll need to know what antihypertensive meds you could give a patient who is pregnant or contemplating pregnancy. And you need to know what meds you would never put in the same room with someone who is pregnant or contemplating pregnancy. So here are the meds that ought to be in your brain, whether you take care of pregnant women or not. The two drug classes that we never want in contact with a pregnant patient are ACE inhibitors and ARBs. The reason we don't want that is because patients who get that have miscarriages. And here's what happens. When a pregnant woman is exposed to an ACE or an ARB, it wrecks the developing renal system in the fetus, and it produces miscarriage. So in a woman who's contemplating pregnancy, ACEs and ARBs are always off the table. So don't give those. What drugs could you use for management of hypertension in someone who's pregnant or contemplating pregnancy? There are a few different drug classes we can use. The two oldest and the two with the longest safety profile are old drugs like methyl-dopa, which was Aldomet, or is Aldomet. You find plenty of people who still use that because it works. Another drug class is hydralazine, which is a presoline. There are people who use that drug, even though it's very old, because it really does work. But the two most recent drug classes are calcium channel blockers, and for whatever reason, these are the three most famous. Nifedipine, verapamil, and diltiazem. Those are safe in pregnant women. and so are the beta blockers. What's our famous beta blocker we use in pregnant women? Labetalol, right? In fact, I like to use that one in patients who are contemplating pregnancy, or at least consider using that one in her. So I think if you know this, what to give and what not to give, I think you've got it. Take a big deep breath. Let's see where you are. Folic acid is recommended prior to and during the first 2 to 3 months of pregnancy to prevent neural tube defects. Absolutely a true statement. Select the examples of neural tube defects. So here's what I think you might see on the exam. They might not use the term neural tube defects. They will use examples. Do you know examples of neural tube defects? Number 1, myelomeningocele, certainly. Spina bifida, whether it's occult or it's not occult, very common. Anencephaly and encephalocele, those are 4 common examples of neural tube defects. That might be the word on your exam instead of neural tube defects. So all of them. Next question. A patient has a fundal height measurement of 24 centimeters at 24 weeks. What does that tell you? It's a good estimate of what? Gestational age of the fetus. Yeah, number 2. A patient is suspected of having diabetes during her initial prenatal visit, and it's in the first trimester. What test or tests could be used to screen for her? Do you know the key word in this question? Screen, right? Screen. What could we use to screen? We could use a fasting blood glucose. We could screen with an A1C. We could screen with a random blood glucose. But number 4 is not a screening test. What is number 4? A diagnostic test, exactly. So circle 1, 2, and 3. Number 4 is a diagnostic test. And look at this one. The uterine fundus should be palpable at 12 weeks. Okay, wait, where? 12 weeks, where is it supposed to be? Number 1 is about 20 weeks, you agree? Number 3 is about 16 weeks. Number 2 is probably about 12 to 13 weeks, you agree? What's number 4? Amelie says number 4 is hopeful. I think number 4 is hopeful. Below the symphysis, well, I guess you're hopeful, right? That's about all I can say about number 4. So wait, what's the answer? Okay, it's not number 4. The best answer, the question asks, where would it be at 12 weeks? It's right above the level of the symphysis. You got it? So right above the level of the symphysis. Look at the picture if you didn't get it. Look at 12 weeks. You see, here's the symphysis is about right there. 20 weeks is at the umbilicus. 16 weeks is midway. You see it? If this is foreign to you, go review it. All right? Last question, here we go. A 3-week postpartum patient has a positive screen for depression. What's his patient's most likely diagnosis? What are you thinking? Well, here's what factors in my brain. I know that if her symptoms occur within 2 weeks after delivery, we say she has postpartum blues. If it is beyond 2 weeks, the term we use to describe is postpartum depression. She's a 3-weeker. Number 2, I think, is your best answer. Everybody got it?